Sounds good. Thank you so much, Dr. Ko, for the introduction. For those coming in, my name is Mena. I'm one of the PGY cardiology residents. And this 6 months, I have the privilege of being the chief cardiology resident here at Sunnybrook. And this morning, I'll be talking to you about the contemporary cardiogenic shock care in Canada and the emergence of novel care pathways to improve patient survival.
Mena, I think your camera is off for some reason. I can't see you anymore.
Okay. So in terms of the objectives for this morning's talk, we will first describe the most common practice in the management of cardiogenic shock, as well as regional variations in cardiogenic shock care across Canada. We'll discuss the approach of a regional care for cardiogenic shock to improve survival outcomes. We'll then explore the possible strategies for developing and maintaining a care pathway for treating cardiogenic shock across the GTA. So I'll move on to discussing what is cardiogenic shock. So cardiogenic shock is a low output cardiac state resulting in life-threatening and end-organ hypoperfusion and hypoxia. It complicates 5 to 10% of cases of acute MI and is the leading cause of death after MI. There are significant regional disparities in evidence-based care, and in-hospital mortality remains significantly high between 27 to 51%. So the initial cardiac insult may stem from various etiologies. So acute MI with left ventricular systolic dysfunction remains the most frequent cause of cardiogenic shock. There was a contemporary registry that had reported that as many as 81% of patients presenting with cardiogenic shock had an underlying acute coronary syndrome. And although 5 to 10% of ACS cases are complicated by cardiogenic shock, this presentation is often associated with a large degree of at-risk myocardium. Other causes include acute on chronic decompensated heart failure, RV failure, arrhythmia, pericardial disease, toxic metabolic effects, as well as valvular or mechanical dysfunction. So this graphic here depicts the pathophysiology of cardiogenic shock. The primary insult is the reduction in myocardial contractility, resulting in diminished cardiac output, hypotension, systemic vasoconstriction, and cardiac ischemia. The hallmark is peripheral vasoconstriction and vital end organ damage, which stems from ineffective stroke volume and insufficient circulatory compensation. Compensatory peripheral vasoconstriction may initially improve coronary perfusion, but it eventually contributes to increasing cardiac afterload, decreased cardiac output, decreased end organ perfusion, and increased volume overload, which then eventually leads to multi-organ dysfunction. In addition, the systemic inflammatory causes pathologic vasodilatation, which releases nitric oxide synthase and peroxynitrate, which have cardiotoxic inotropic effects. Interleukins and tumor necrosis factor alpha are additional systemic inflammatory mediators that result in vasodilatation and contribute to mortality in patients with cardiogenic shock. So what are the hemodynamic phenotypes in cardiogenic shock? So patients with cardiogenic shock most commonly present with cool extremities and signs of pulmonary congestion. This presentation is termed cold and wet and reflects a reduced cardiac index, increased systemic vascular resistance, and increased pulmonary capillary wedge pressure. Patients may also present as euvolemic or dry and cold, which indicates a reduced cardiac index, increased systemic vascular resistance, and a normal pulmonary capillary wedge pressure. Euvolemic presentations were most likely to have previous MI or chronic kidney disease in comparison with those with classic cold and wet features. One of the most under-recognized presentations of cardiogenic shock is the warm and wet patient. This represents a systemic inflammatory response syndrome reaction in conjunction with a myocardial infarct and is associated with a higher incidence of sepsis and mortality. And these patients have a reduced cardiac index, low to normal systemic vascular resistance, and an elevated wedge pressure. So here's the traditional bedside diagnosis of cardiogenic shock. So you have the hemodynamic definition, which is evidence of hypotension with a systolic blood pressure less than 90. Vasopressors are inotrope used to maintain a systolic blood pressure greater than 90 systolic, or a cardiac index less than or equal to 2.2 and a wedge greater than 15. There is a clinical and laboratory definition, which is evidence of hypoperfusion, as well as a lactate greater than 2 for over 2 hours. And this definition all implies frequent trending of hemodynamics and organ perfusion, plus or minus invasive PA catheter use for early detection and timely management decisions. And unfortunately, one size really does not fit all with cardiogenic shock because it is quite a heterogeneous disease process. And the fact that the definitions have varied across various studies have really prevented it from having advancements in research and a unifying diagnosis. Up until the SCAI group came up with this algorithm. So in search for a common language for defining cardiogenic shock severity, the Society for Cardiovascular Angiography and Interventions, or SCAI, put out a 5-stage A to E classification system for cardiogenic shock. It's meant to be simple and intuitive without the need for any calculations. It adds the needed granularity in severe shock. It's suitable for rapid assessment at the bedside. It allows for frequent reassessment and reclassification. It can be applied to retrospective data sets or prior trials to re-examine outcomes and future trials to better define the included population. It also provides a new lexicon for communication between providers, including the facilitating multidisciplinary teams that would be involved in managing cardiogenic shock. And this sort of speaks to the hub and spoke model, which I will be presenting shortly. It also provides an easy to remember way of defining cardiogenic shock, similar to the Intermax model. So how do we define patients using this classification system? So in stage A, we have a patient who is not currently experiencing signs and symptoms of cardiogenic shock, but is at risk for its development. And these patients are those that have an NSTEMI or a STEMI or acute on chronic CHF presentation. In stage B, that's the beginning. And this is a patient who has clinical evidence of relative hypotension or tachycardia without hypoperfusion. In stage C, we have a classic patient who has hypoperfusion that requires interventions such as inotropes, pressors, or percutaneous mechanical circulatory support to restore hemodynamics. In stage D, we have a deteriorating patient who are similar to stage C, but are actually getting worse. And these patients have failure to respond to the initial interventions that have been initiated. And in stage E, the patient is an extremis, and these patients are either in cardiac arrest undergoing CPR or ECLS placement, and alternatively, they're being supported with multiple interventions and inotropes. There is a risk modifier for cardiac arrest. So any cardiac arrest, however brief, so if the patient received defibrillation or CPR, would name the patient differently. For a patient who had a hospital cardiac arrest, as well as cardiogenic shock, they would be classified as SCAI Shock Class B with brackets A. And this is a patient with relative hypotension and tachycardia without hypoperfusion who suffers a witnessed VF arrest and has successful defibrillation and remains without signs of hypoperfusion. If there's any signs of hypoperfusion that develop after the arrest, the patient would be then SCAI Shock Class CA and in need of initial efforts to restore perfusion. And if those efforts do not work, the patient is now SCAI Shock D in brackets A. So in our case, our patient was SCAI Shock D A, being on a balloon pump, not getting any better from a hemodynamic perspective, and eventually showing worsening hypoperfusion and poor urine output. And interestingly, the nomenclature system has been retrospectively validated and correlated to in-hospital and cardiac intensive care unit mortality. So here's a study that sought to apply the SCAI Shock classification in a cardiac intensive care unit population. They retrospectively analyzed Mayo Clinic CICU patients admitted between 2007 and 2015. SCAI cardiogenic shock stages A through E were classified retrospectively using CICU admission data based on the presence of hypotension or tachycardia, hypoperfusion, deterioration, and refractory shock. Hospital mortality in each SCAI shock stage was classified by cardiac arrest. There were 10,004 unique patients identified in this study. And in a multivariable adjustment, each higher SCAI shock stage was associated with an increased hospital mortality. And the results were consistent in the subset of patients with acute coronary syndrome or heart failure. So when assessed at the time of CICU admission, the SCAI cardiogenic shock classification, including presence or absence of cardiac arrest, provide robust hospital mortality stratification, which will hopefully eventually help in patient management. So here we've identified cardiogenic shock, its severity, whether it's LV or RV, dominant or both. So what are the next steps we have in management and who can help us manage our patients? So here I'm illustrating how cardiogenic shock management is truly a team-based sport. It starts off in the emergency department, and emergency department care is really key in the early recognition and treatment of cardiogenic shock, particularly in acute myocardial infarction cardiogenic shock, which requires timely acquisition and interpretation of a 12-lead ECG by the emergency medical personnel, and immediately transfer this patient to a PCI-capable facility. And although patients with pre-shock may proceed directly to the cath lab, those with SCAI stages C or D cardiogenic shock may first require stabilization with vasopressors or mechanical ventilation. And although we really don't want to delay reperfusion, we certainly need to stabilize these patients first to prevent further complications. In patients with SCAI stages E or end-stage cardiogenic shock in whom aggressive therapies are futile, palliative care consultation or goals of care discussion would be warranted at that time. In terms of invasive hemodynamic monitoring, despite an absence of benefit of routine PA catheter use for heart failure, there is growing evidence that supports the benefit of early invasive hemodynamic assessment in patients with cardiogenic shock, particularly in that PA catheter use may lead to earlier and more accurate identification of the cardiogenic shock phenotype so that medical and device-based therapies could be applied appropriately. So given these considerations in usually single center studies, the routine use of early invasive hemodynamics has been advocated as sort of the standard of management for contemporary cardiogenic shock, even though more studies are required to validate this. And in terms of mechanical circulatory support, so they're increasingly in use in cardiogenic shock to stabilize hemodynamics, although exactly when, how, whether we should even be using them or incorporating them in cardiogenic shock certainly remains controversial. Device selection should be really guided by the acuity of the illness, the cardiogenic shock phenotype, the degree of circulatory and ventricular support required, the vascular access or anatomy of the patient, the experience of the center the patient is at, as well as the expertise of the multidisciplinary teams involved. And then we have the cardiogenic shock team. So what is this cardiogenic shock team? So the team actually comprises of a heart failure cardiologist, a heart failure cardiothoracic surgeon, an interventional cardiologist, as well as a CICU attending physician. So once activated, all team members are meant to participate in the decisions surrounding patient management and the therapeutic options available for the patient. And activations after hours or on weekends do not automatically bring all the on-call staff in, but it at least initiates a discussion between the key players involved. The heart failure cardiologist usually performs the initial screening when clinical suspicion of cardiogenic shock exists, and that physician serves as the central hub for coordinating the whole process.
Mena, can I just maybe just pause a little bit? Can I just go back to that slide? So I guess one of the things in the community, the diagnosis of cardiogenic shock remains pretty difficult, right? We get a lot of phone calls from the hospital, patients hypertensive, they have some ECG changes. From this, sepsis, like it's not that easy to diagnose cardiogenic shock based on just blood pressure and lactate. I just wonder if you can comment on that, because we just get a lot of calls for cardiogenic shock that turn out not to be.
Yeah, no, that's a great question. I think it really has to do with understanding the entire clinical picture. I think if somebody is presenting with, an acute myocardial infarction quite hemodynamically unstable, their risk of developing cardiogenic shock is quite high, and the most common cause of cardiogenic shock is acute myocardial infarction. So taking those patients to a PCI-capable facility off the bat, even in the absence of a code STEMI, would probably be the best for managing that patient. In those cases where it's a bit more undifferentiated, I agree with you. That's going to be the difficult part, is trying to educate EMS or even emergency providers about how heterogeneous the presentation of cardiogenic shock can be and how confusing it could be with sepsis. But a quick physical exam is also quite important. So when a patient is shut down or cooled peripherally, coming in with elevated troponin, an ECG that's not necessarily diagnostic, no real hints or clues or physical findings of sepsis, I would be questioning cardiogenic shock in that case. But I think the biggest takeaway for me is in triaging patients that would arrive to a PCI capable center, in my mind, it's no longer STEMI versus NSTEMI. It's, does this patient need eventual assessment for complications of a high risk and STEMI that may include cardiogenic shock, and would they benefit from being at a center that is capable of doing PCI on an urgent basis and or starting the workup for advanced therapies if needed, especially in younger patients. All right, so I'll continue on here. So why are shock teams important? So when we're looking for ways to improve outcomes in clinical practice, it's important to recognize where the cardiogenic shock patients are presenting. And this sort of alludes to the point that I was speaking on. But approximately 90% are seen in the community, and these are even PCI capable centers. And while the average size of the cath lab where this patient would present has changed, in 10 years, approximately 70% were centers that had greater than 500 PCIs per year. But in the most recent data, it's now down to about 50-50 between small and large volume cath labs. So a lot of our patients are actually not coming to our centers, but rather at centers affiliated with ours. And they may or may not have PCI capability, but certainly would benefit from a team-based approach to discuss patients that are higher risk. So this paper was just published back in September on the management outcomes of cardiogenic shock in cardiac ICUs with versus without shock teams. So this study really acknowledged the fact that there are many single center studies that suggested that the implementation of multidisciplinary cardiogenic shock teams were associated with improved survival. So they aim to characterize practice patterns and outcomes in the management of cardiogenic shock across multiple centers and looking at centers with versus without shock teams. So they employed the Critical Care Cardiology Clinical Trials Network, which is a multi-center network of cardiac intensive care units in North America. And they had about 24 centers involved and looked at data capturing a 2-month collection period between 2017 and 19 for a total population of 6,872 patients. And the outcomes were shock management and CICU mortality among centers with versus without shock teams. So 10 out of the 24 centers had shock teams, and among 1,242 cardiogenic shock admissions, 44% were at shock team centers, and the shock team centers had about 546 patients, and no shock team had 696 patients. And the groups were well balanced, as demonstrated by this table, with respect to their demographics, their shock etiology, their sequential organ failure assessment score, their biochemical markers of end organ dysfunction, and invasive hemodynamic use. So these are the interesting findings of the study. So they found that institutions with shock teams had significantly higher rates of Swan-Ganz catheterizations, which were typically placed in less than 1/2 of the time. The median number of inotropic agents per patient was also lower at shock team centers. Patients with cardiogenic shock that were treated at centers with shock teams had shorter CICU stays and lower rates of both mechanical ventilation and new renal replacement therapy. CICU mortality was lower in adjusted analyses in centers with shock teams. The medical centers with shock teams also showed significantly more advanced types of MCS while using less mechanical circulatory support overall, which I found was particularly interesting. And this was driven by less frequent use of intra-aortic balloon pumps. The preference towards advanced mechanical circulatory support was observed with regards to both initial and overall MCS device selection. So what are sort of proposed regional systems of care for cardiogenic shock? So this illustration depicts a potential way of organizing the system. And in part A, you see a patient with cardiogenic shock that's diagnosed in the field by EMS. And again, most typically this would happen if the patient had an acute myocardial infarct rather than decompensated heart failure and worsening shock, which can, again, as Dr. Ko mentioned, be mistaken for other etiologies of illness. And so this patient would be transported directly to a hub cardiogenic center, bypassing the nearest spoke facility, which is a facility that wouldn't necessarily offer a shock team or invasive management if needed. In part B, you see cardiogenic shock pathogenesis, travel time, and spoke center capabilities that factor in to the decision to bypass a spoke hospital. So STEMI patients certainly need to be transferred to a PCI facility for revascularization and stabilization, and patients with unclassified shock should be transferred to the nearest emergency department for further workup prior to being transferred to an alternative center. In C, you can see patients that are presenting to a spoke PCI capable hospital where revascularization and stabilization can be initiated. Then a physician to physician dialogue can happen with the hub center or the advanced cardiogenic shock center. And that can happen as soon as the diagnosis is made and a requirement of potential advanced therapies is required. And in D, this is an interesting addition. This is a mobile unit from the hub center or the cardiogenic shock center that can be deployed to the spoke hospital to stabilize and initially transfer the patient from a spoke center to a cardiogenic shock center for definitive management. And patients presenting to smaller spoke centers without PCI capabilities should be immediately transferred to the nearest PCI facility. Or if that's not possible, they're presenting a fact that the shock mobile unit could be requested from the hub cardiogenic shock center. And depending on the patient's clinical status and anticipated travel time, this might help bridge the connection so that there is no delay in care. However, as one can imagine, there's a huge resource limitation in deploying medical personnel from one site to another or from one cardiogenic shock hub to a peripheral spoke hub. And this is sort of the proposed cardiogenic shock center characteristics. So they quantify tertiary centers as high volume cardiovascular centers that can be designated as cardiogenic shock patient receiving or the hub centers. And then within each cardiovascular system of care, these centers would accept transfers from appropriately selected institutions that have cardiogenic shock patients that require further investigation and treatment that is not possible at the referring center. And to consolidate the clinical volumes, the recommendation is that there is one hospital designated as the hub, and that hospital would have cardiovascular ICU level care, CICU level care, cardiac surgery, as well as communication with a transplant center should that be required. And those kinds of communications would happen with the spoke or peripheral hospital to determine what the appropriate next steps are. So this is an interesting Canadian article that was published in 2020 looking at the multidisciplinary code shock team at the Ottawa Heart Institute. And in this study, they reviewed 100 patients that were admitted with cardiogenic shock over 52 months. And these patients were managed under a code shock team protocol from 2016 to 2019 and were compared to patients that underwent standard of care from 2015 to 2016. So this is the University of Ottawa Heart Institute Code Shock Protocol. And as shown in figure 1, it's a 4-step protocol, which involves 1, the identification of patients in cardiogenic shock, 2, a CCU review to confirm fulfillment of cardiogenic shock criteria, as well as activation of a code shock. In 3, you see advanced heart failure review with subsequent code shock activation if deemed appropriate. And in 4, the shock team reviews for resuscitation, medical optimization, decision-making on temporary mechanical circulatory support, including candidacy, timing, device choice, and implant strategy, as well as the evaluation for durable left ventricular assist device and heart transplantation in the appropriate patient. And interestingly, they had a smartphone-based application to use for code shock activation and virtual online discussion among the shock team. And then eventually the shock team would perform bedside rounds at least daily where the patient was admitted. And this is separate to the intensive care unit rounding that they had. So here you could see that the cohort was predominantly male with a median age of 55 years for treatment versus 65 years for control. New heart failure was more common in the treatment group, 61% versus 36%. Acute MI compromised 13% of patients in cardiogenic shock. And there was no significant difference between treatment and control in the markers of clinical acuity, including median left ventricular ejection fraction, prevalence of moderate to severe right ventricular dysfunction, medium.
Treatment and control, is it a historic control or what's?
Yeah, so what they did was they used patients from 2016 to 2019 and compared them with patients from 2015 to 2016 before the implementation of their code shock protocol. So they did a prospective and a retrospective.
Yeah, and I just was surprised that the age is so much younger. After.
Yeah.
But they also had a cutoff of 70 years of age, if you look at that. So no one over the age of 70 was getting into either protocol.
That's correct.
Yeah, but usually when you kind of do like a pre and post study, you know, if you have a similar, like I'm just saying it's kind of a lot of selection when your age drop by about 10 years after you implement something, which it's okay, but it's okay.
Yeah, and I think also for patients that they would triage for advanced therapies, I'm sure there's an age bias as well. So typically any age above 70, unless the patient is remarkably fit or non-comorbid, would not necessarily be considered for advanced therapies from the jump. So maybe that part has to do something with it, but certainly an interesting observation with the baseline data. So here are their results. So the inotropes, dialysis, and invasive ventilation were required in 92%, 33%, and 66% of patients respectively. Temporary mechanical circulatory support was used in 45% of the treatment or the code shock team protocol patients and 28% of control patients. So certainly more mechanical circulatory support was used upon the introduction of the shock team. There were no significant differences in median hospital length of stay in this study, 30-day survival or survival to hospital discharge. Over 240 days of median follow-up, though, survival was 67% for the treatment group versus 42% for the control group. So they conclude that a multidisciplinary code shock team approach for cardiogenic shock could be feasible and may be associated with improving long-term survival, but not necessarily short-term or in-hospital survival. So where do we go from here? So this was recently presented by Dr. Overgaard at the Canadian Cardiovascular Congress last week about the multidisciplinary approach to cardiogenic shock care. And this algorithm he presented includes community hospitals, regional STEMI hubs for PCI capable hospitals that are able to put in balloon pumps but do not have CV surgery access and no 24-hour house staff. And then the regional shock hub, which would absorb patients from multiple different centers that are PCI capable, that have a CICU, that have cardiac intensivists as well as a heart failure team, but are limited with respect to mechanical circulatory support, and that have CV surgery as well as 24-hour house staff. And then you have the transplant VAD shock hub. So for our center, we would probably be a regional shock hub and would eventually communicate with UHN as the transplant VAD shock hub in the appropriate patient, should we have a patient that requires advanced care. So what are some limitations to trying to implement shock teams? So organizationally, it's quite challenging to try to coordinate a multidisciplinary team, an on-call service at multiple different centers. Sometimes we have a lack of mobile equipment and resources. And we find this even in cases where patients require ECMO cannulation and there's a limitation in sending a group from one center to another. It's challenging to develop regional hub and spoke centers because sometimes the referral patterns are misaligned with the types of centers available. And sometimes there is a lack of cardiogenic shock familiarity at spoke centers, mainly because the volumes might be different and lower at certain institutions compared to others. There is also challenges in measurement and feedback, and we lack a national cardiogenic shock registry at the present time. And there is also a lack of universal cardiogenic shock specific care quality indicators or guidelines. So certainly the development of appropriate ways to measure and feedback processes would be helpful, as well as a way to coordinate and implement a program would be particularly helpful. There has been a trial here at UHN, or like an attempt to centralize cardiogenic shock management. And this is the UHN and Sinai Health Network Cardiogenic Shock Algorithm that was developed by Dr. Luck. And essentially it provides a way to identify a patient that has suspected cardiogenic shock and then implement a management plan by paging the on-call heart failure staff, and if necessary, activating critical to bring a patient down to an advanced heart failure center. And depending on whether the patient has presented with acute MI versus acute decompensated heart failure, the management principles are different in terms of cath lab care and revascularization versus having a right heart cath, as well as an urgent echocardiogram to assess ventricular function and start implementing inotropic therapies if necessary, while simultaneously considering workup for advanced therapies. So this is what is being tried over at the UHN. And this algorithm is being distributed to several different centers to try to centralize the care of cardiogenic shock patients across the GTA. Sort of summarize, this is one of the graphics recommending a multidisciplinary shock team. So for the case of an acute MI or a high-risk NSTEMI, cardiogenic shock, the recommendation is to send the patient to a center that has capability to perform PCI, and activate the team appropriate to manage the patient with cardiogenic shock, which would include a heart failure specialist, a cardiac intensivist, plus or minus a cardiovascular surgeon. And again, as redemonstrated, the model of a hub and spoke, where the shock team is located at the hub with contributions from spoke hospitals in the management of patients who are critically ill and diagnosed with cardiogenic shock. And here's a slide demonstrating the next steps in this area. There's tons of research that still needs to be done in terms of the PA catheter use, timing, utility, the relevance of tailored therapeutics and mechanical circulatory support and their effect on outcomes, revascularization in acute myocardial infarcts, and complete versus single vessel revascularization is one area of interest that has been studied in culprit shock, but certainly requires further randomized control trials for more robust recommendations. Vasopressor and inotrope use, and the Do-Re-Mi trial just came out of Ottawa, but certainly room for more trials to provide us with advice in the acute management of cardiogenic shock using vasopressors and inotropes, as well as care delivery models. And as Dr. Radhakrishnan mentioned, trying to find the funding to actually do these studies and implement these shock teams is also prudent and will require a lot of logistics and planning. So to summarize today's session, cardiogenic shock remains a very significant driver of morbidity and mortality, particularly in acute MI patients. And in the development of cardiogenic shock centers, there needs to be protocolized care with a focus on a consistent definition, staging, phenotyping, and early recognition of cardiogenic shock. Multidisciplinary shock teams have demonstrated improved survival outcomes, though these are modest to date, and certainly more data is required to truly hone that in. And future RCTs are necessary to guide proper device utilization, as well as tailored therapies in these settings. So with that, I will close and open up the floor for any questions or comments. And I thank you for your attention.
Thanks a lot, Mena. Do you want to just close your slide so we can just see whether people have any questions? Let me just call in. Sam or Eric, do you want to start?
Sure, I'll start. I mean, I think this was excellent, Mena. Cardiogenic shock is heterogeneous, but that heterogeneity, excuse my challenge, makes it even more challenging to figure out who's the right patient to bring over, right, and make a difference on. Plus, as you highlighted, even some of the therapies that we currently have, for example, a balloon pump, is not seeming to, in the clinical trial, ABI Shock 2, didn't actually make a difference. Now, we all still use it because we actually think it does make a difference, but the data there is not robust. And even with regards to Impella, the data is missing in terms of who to start, when to start. When to start is actually easy, as early as possible, but when not to use in shock. So I think there's a lot that is missing before a full-on hub and spoke model can go live. And you're advocating that let's do it so we can get the data, and that's absolutely true. I agree with you. When we started STEMI, we had as a baseline that primary PCI care is the clear winner, right? If you can deliver timely primary PCI care, it's a no-brainer that it serves patients well and it ultimately serves the healthcare system well. It's not entirely clear because of all the different challenges involved. Where do we find that perfect patient for a hub and spoke shock protocol? So these are some of the challenges, but the biggest challenge, is if we were to go to Andy Smith and say, hey, let's take on all these shock patients. I know we have 0 ICU beds, but we're going to add to that by having more patients that are no refusal. It's hard to justify that. We had a challenge even bringing in Impella because of the limited data. That exists with Impella in this situation. I think this exploration over the next 5 years, and hopefully we come to some hub and spoke model. I'm just not sure that we're there.
Eric, you want to say something? And anybody in
residence
or anybody else wants to ask a question, let me know.
I was just going to say, I can't tell when Sam stopped talking or when his internet cut out. I can't tell the difference.
I have stopped talking here.
I'll make a quick comment if nobody else has a comment. I don't want to monopolize, but number one, I think that was great. You covered so much material and there's a lot for us to cover. Number two, I think the shock team concept is a given. It's a no-brainer. I don't really care what the studies actually show. The concept of having a team is not an expensive concept, and the idea that one interventional cardiologist in the middle of the night trying to, as a code STEMI and the patient's in shock, dealing with this all alone, that just doesn't fly. So the idea of bringing more brains to bear, especially people with different expertise, is a given. The hub and spoke thing, I think, because Sam said it requires a lot of investment and restructuring of some pathways, is a trickier one. Toronto represents probably a very challenging issue, right? Because under the model you outlined there, we would be a regional hub, and UHN would be the transplant VAD center, and that's fine. It's just that when we started the STEMI program, what you did see was some diminishment of expertise in looking after acute MIs in the non-PCI hospitals. So if you extrapolate this, would it lead to a diminishment of the ability to look after shock in large PCI centers like our own, because the sickest ones get transferred out? And that might be okay if you knew in advance who was going to be the shock patient. But your MI patients who come under the STEMI protocol, some of them become shock patients. So you've got to have some expertise at all these sites. So I think that's one of the challenges, but I think it's going to be very interesting over the next 10 years, just as it was when the STEMI program was brought in.
Yeah, no, that's a great point. But, one thing I was thinking about when you were speaking is, one of the recommendations was like this mobile team that ends up going out. But again, it's so resource intensive that if we start getting just like we get consults for code STEMIs, it might end up being that we get consults for cardiogenic shock. And sometimes it's very difficult to make those decisions over a telephone call or sort of just in conversation. This is something that really requires that patient assessment. But yeah, no, it's well taken that resource limitation, financial limitation, draining expertise from collaborative centers. Yeah, I know, I totally agree.
I'm gonna go to the cardiology residents, and then Shahida just raised her hand. So I don't know who is in the resident room, but it's nice to see everybody there.
We have a lot of people. Hey, Mena, it's Mike. Thanks so much for the excellent talk. I just had a question. So about the most recent paper that came out, the Popoulos et al. In JACC, that compared shock centers versus non-shock centers. Obviously, a big theme of the discussion has been around like selecting the right patient and who is the right patient. I guess my question is, a lot of times when we see these patients, the head of the bed test really kind of makes a difference, and it's hard to capture that in a research setting. Were these patients that were at non-shock centers, if they were deemed to be good candidates, were they allowed to be transferred to shock centers, and could there have been some selection bias in this study?
Yeah, no, that's an excellent question. So in this particular study, they looked at defining cardiogenic shock in a very homogeneous way. So by blood pressure criteria, laboratory investigation criteria, and clinical findings. So they essentially just manage by standard of care. So the standard of care at a shock center would have been this group decision-making, use of PA catheters, use of mechanical circulatory support, and at non-shock centers is the routine medical management, which will still require vasopressors, inotropes, but not necessarily the degree of advanced therapies. So I agree with you, and this happens in real life as well when you're dealing with a patient who's critically ill. At a non-cardiogenic shock center, this is actually what may happen, is that they would get the standard of care, which is the usual medical therapy plus or minus PA catheter, depending on the center. And if there is no PCI capability at that particular center, they're transferred out. But in terms of the actual advanced therapeutic management, that was specific to the shock team. So certainly could impact a bit of bias.
Thanks. I'm going to give the last question to Shahida. She had her hands up for it. Shahida?
I just want to say thank you. That was really outstanding. I learned a lot. Just a couple of comments I wanted to support and echo. Eric's concept of working in teams, especially when you're dealing with a sick patient, so important. I don't think anyone enjoys taking care of that situation, and it would make sense to have a team-based approach when you're dealing with complex patients in general. The other quick observation is it's interesting that the two models for shock protocols came out of Ottawa and then later the UHN. And just as an observation, across the country, to my knowledge, the only two cardiology training programs that have in-house residents are also Ottawa and UHN. And so as we move forward, potentially developing, shock models, we need to think about the human resource, not just at the staff and the allied health level, but also at the trainee level. And how does that factor in? Because there's so many different moving parts that need to be considered for things to run well.
Yeah, that's a great point. I didn't even think of that with respect to the in-house staff that would be capable. But yeah, certainly it would change the outlook, especially at centers like Queen's and London.
I see the residents are looking at the schedule calendar already. But again, thanks a lot, Mena, for giving us this great talk. Cardiogenic shock is always kind of interesting. It doesn't happen a lot, fortunately, but it's always something that we think we can do a lot better. So I really appreciate you coming. You just set a great example for future chief residents. So thanks a lot, everybody, for coming.
Thank you so much for the opportunity. Have a great day, everyone. Thanks for tuning in.
Bye.